Take a look at this transesophageal echocardiographic view. A normal interatrial septum is demonstrating, but the septum can occasionally become a source of diagnostic uncertainty. Most cardiologists are familiar with a patent foramen ovale, which is frequently considered during the evaluation of cryptogenic stroke. However, an even more common but less appreciated finding is the interatrial septal pouch, particularly in patients with embolic stroke of undetermined source. In this TE view, a large interatrial septal pouch is demonstrated. An interatrial septal pouch is a blind-ended pocket located within the interatrial septum. It results from incomplete fusion of the septum primum and septum secundum after birth. Normally, these septa fuse completely following closure of the foramen ovale. When fusion is incomplete but no residual communication remains between the right and left atria, a pouch may persist. The pouch can open toward the left atrium, right atrium, or both atria. It is believed that blood may enter the pouch, then flow velocity becomes low, creating conditions that could favor thrombus formation and subsequent systemic embolization. Although interatrial septal pouches can be found in up to 40 to 50% of the general population, the higher prevalence in patients with cryptogenic stroke, raising the possibility of a causal relationship. Transesophageal echocardiography remains the gold standard for diagnosis. The hallmark echocardiographic finding is a blind ending sac within the interatrial septum that communicates with only one atrium. Color Doppler demonstrates flow entering the pouch without evidence of transseptal flow, while contrast echocardiography confirms the absence of a shunt. Three-dimensional transesophageal echocardiography provides excellent visualization of the pouch, allowing assessment of its size, shape, orientation, and the presence of thrombus. Indeed, the pouch may behave like a mini left atrial appendage. Despite all these observations, the interatrial septal pouch has not yet been established as a definitive source of cardioembolism. Therefore, in a patient with cryptogenic stroke, identification of an interatrial septal pouch should not stop searching for other embolic source. An alternative hypothesis is that the interatrial septal pouch may serve as a marker of underlying atrial cardiomyopathy rather than being the primary cause of embolic events. In fact, a thrombus formation within the pouch may represent an early echocardiographic manifestation of an atrial thrombogenic state. Some investigators suggest that the depth, shape, and neck dimension of the pouch may change during age or atrial stretch. The interatrial septal pouch may be a forgotten chamber during embolic workups, and it is often overlooked during evaluation of left atrial appendage, left ventricle, and aortic arch. However, the clinical significance of an interatrial septal pouch appears greatest when it coexists with other atrial disease, such as left atrial enlargement, atrial dysfunction, atrial fibrosis, atrial fibrillation, or systemic hypercoagulability. Whether future evidence will elevate the interatrial septal pouch from an anatomical curiosity to an independent cardioembolic source remains uncertain. For now, it remains one of the most fascinating unresolved questions in structural echocardiography and stroke medicine.